Good afternoon, everyone, and a warm welcome to this virtual masterclass on role of saliva in prosthodontics, conducted by HKES'S NIJALINGAPPA College of Dental Sciences, Kalaburagi, in association with the Indian Prosthodontic Society, Karnataka State Branch. I am truly honored to be addressing the postgraduates and the distinguished faculty members. It is a proud moment to conduct this session, me being an alumni of the host college. HK College. Before we proceed, I would like to take a moment to express my sincere gratitude to the organizers of this session, especially my teacher, Dr. Arvind Muldi sir, Department of Prosthodontics, and the coordinating team for providing this excellent platform for academic exchange. It is indeed a privilege to share this session with all of you, and I look forward to an engaging and insightful discussion ahead. Here is a list of the learning objectives which will be covered in the following presentation. Saliva, though often overlooked and taken for granted, plays a pivotal role in maintaining the oral health and in the success of prosthodontic rehabilitation. Its function extends beyond simple lubrication. It is essential for mastication, deglutition, speech, and the protection of the oral tissues, from influencing the retention and comfort of removable prostheses to determining the longevity of fixed restorations and implant supported prostheses. Saliva is truly an integral biological factor in our clinical practice. So, in this session, we will explore the composition, physiology, diagnostic significance, and the clinical implications of saliva in prosthodontics, aiming to deepen our understanding and enhance the treatment outcomes. Coming to the definition, saliva is a clean, tasteless, odorless, slightly acidic viscous fluid consisting of serous secretions from the parotid, sublingual, submandibular salivary glands, and the mucous salivary glands of the oral cavity. Moving on to the classification of salivary glands, it can be classified according to the size and according to the nature of secretion. According to the size, we have major salivary glands, parotid, submandibular, and sublingual, and minor salivary glands depending on the location in the oral cavity. They are named as labial glands, buccal glands, minor sublingual glands, glossopalatine, lingual glands, palatine glands, glands of von Ebner, and glands of Blandin and Nunn. They are numerous in number. According to the nature of secretion, parotid and glands of von Ebner are purely serous, whereas buccal, palatine, and sublingual gland are purely mucous in nature. And we have mixed salivary glands that are submandibular, which is predominantly serous, and sublingual, which is predominantly mucous. Moving on to parotid gland, the largest serous salivary gland, which is pyramidal in shape and weighs around 25 grams in weight. It develops in the corner of the stomodium in the 6th week of the intrauterine life. And the secretions of this gland open in the gingivo-buccal vestibule in the crown opposite, the maxillary second molar area through the Stenson's duct, which is having a thick wall and a 5 centimeter in length. Coming to the submandibular gland, the gland is J-shaped and it gets divided into two parts. The deeper part, which is smaller in size, and the largest superficial part. It develops from the floor of the mouth at the end of the 6th week of intrauterine life. It opens on the floor of the mouth on the summit of the sublingual papilla at the side of the frenulum of the tongue. The duct is a Wharton's duct. It is thin-walled and about 5 centimeter in length. Now coming to the sublingual gland, which is the smallest major salivary gland, which is like an almond-shaped, weighing around 3 to 4 grams. It contributes only 5% of the total salivary secretion. It is located in the anterior part of the floor of the mouth, between the mucosa and the mylohyoid muscle. They are the last major salivary glands to form, appearing in the 8th week of the intrauterine life, and the gland develops lateral to the submandibular primordium from the epithelial buds of the floor of the mouth. The sublingual gland has a major duct, which is the Bartholin's duct, and the duct's majority of the secretions opens into the floor of the mouth. Now moving on to the minor salivary glands, they are numerous, around 6,000 to 1,000 small encapsulated exocrine glands located beneath the oral epithelium in almost all parts of the oral cavity except in the gingiva, anterior hard palate and the anterior two-thirds of the dorsum of the tongue. They are relatively small, measuring around 1 to 5 millimeters in diameter, contributes around 8 to 10% of the saliva. Unlike major salivary gland, they lack a distinct capsule, help keep the oral mucosa moist, facilitating functions like swallowing and speech. Minor salivary glands are vital source of protective components like IgA, lysozymes, and other antimicrobial substances that defend against bacteria and viruses. Saliva from these glands contains enzymes like amylase, which aid in the initial breakdown of the food. Now, structurally, salivary glands consists of secretory units called acini and a branching ductal system that transports saliva to the oral cavity. Acini are composed specialized secretory cells, both serous and mucous in nature, which are the functional cells that produce primary saliva. The duct system includes small, delicate, intercalated ducts and the larger striated ducts that modify the saliva. And finally, the main excretory ducts. The myoepithelial cells, which wrap around the secretory units and the intercalated ducts, contract to squeeze saliva through the system. A note to make here is as age progresses or as age increases, there is decrease in the acini cells, which leads to xerostomia. Coming to the formation of saliva, saliva is produced in two stages, stage 1 and stage 2. Stage 1, it's primary cell secretion, and in stage 2, it is the modification of the primary secretion. The saliva contains serous and mucinous cells within the salivary glands, along with the other contents which are contributed by the plasma, gingival clavicular fluid, oral epithelium, debris, and the microbial subproducts. Serous and mucous cells differ intracellularly and morphologically and are clustered in the acini, arranged in lobules within the glandular parenchyma. Acinar cells contributes the most protein and peptides to the final saliva. They secrete the isotonic saliva into the duct system. It is in these ductal system that the primary saliva, which is isotonic, undergoes optimization and modification, where when through intercalated ducts, cells secrete minor portions of proteins, and then through striated ducts, cells mediate electrolyte exchange, secretion, and resorption, modifying saliva from isotonic to hypotonic. As saliva reaches the excretory ducts, the electrolyte content is continuously modified. Final saliva produced from salivary glands has a pH which ranges around 6.5 and is composed of proline-rich proteins, amylase, cystidins. Coming to the type of saliva, according to the type of secretion, we have purely serous, purely mucous, mixed, where predominantly serous by submandibular salivary glands, mixed, that is predominantly mucous by sublingual glands, and according to the source of secretion, we have gland-specific, whole saliva, and based on the collection method, we have stimulated saliva and unstimulated saliva. According to the source of secretion, we have gland-specific from salivary glands collected directly from the glands, and the mix of secretion from the major and minor salivary glands along with the GCF and the other fluids which form the whole saliva. Based on the collection method, stimulated saliva flow rate 4 to 5 ml per minute, mainly derived from the parotid glands, which is almost more than 50% of the contribution of the whole complete saliva. While unstimulated saliva flow rate is around 0.3 to 0.4 ml per minute, mainly derived from submandibular glands, contributing to different composition and volume of the final saliva between stimulated and resting states. Moving on to the secretion of saliva. The secretion of saliva is regulated by nervous system in response to various stimuli like smell, taste, and mechanical action. Salivary glands are under the control of autonomic nervous system and receive efferent fibers from the parasympathetic and the sympathetic divisions of ANS. The parasympathetic innervation increases serous secretions by stimulating SNR cells to release water and electrolytes, while the sympathetic innervation increases proteins. Now, factors affecting the salivary secretion. We have physiological factors and pathological factors. Physiological factors like age, hydration, taste, smell can stimulate the salivary secretion. And whereas the pathological factors, the conditions like digestive tract irritants, poor fitting dentures, trauma from surgery, increased salivation, whereas the irradiation therapy, diarrhea, atrophy of the salivary glands, and diseases of the brainstem reduce the salivary flow. Now, there are few drugs which affect salivation like cholinesterase and physostigmine. They increase salivation, and pilocarpines also, salivox, they also increase salivation, whereas antihistamines, drugs for peptic ulcer, antihypertensive, antipsychotics, anti-anxiety drugs, and antidepressants reduce the salivation. Moving on to the composition, on a daily basis, around 1 to 1.5 liters of saliva is secreted. Jokes apart, it is said that in a year, one person can almost fill 2 bathtubs. That amount of salivary secretion happens in our oral cavity. The pH range from around 6.3 to 6.85. 99.5% of water and 0.5% of organic and inorganic substances are present. Now, inorganic components like electrolytes, sodium, potassium, calcium, chloride, phosphates are present. Bicarbonates, which acts as a buffer to maintain the neutral pH and protect the teeth. Other ions include bromides, fluorides, and iodine. The organic components, enzymes like amylase, which begins the digestion of carbohydrates, and lingual lipase, which starts the digestion of fats. Lysozyme has an antibacterial agent. And we have proteins and peptides like mucins, which are more complex protein molecules that provide lubrication and form the mucus layer in the mouth. Lactoferrin is an antimicrobial protein, and other proteins such as proline-rich proteins, cystatin, salivary peroxidases have a role in buffering, which buffers the acid produced by the oral bacteria and hence prevent enamel demineralization. Immunoglobulins like IgA, they are the antibodies that provide immune defense by neutralizing the bacteria and the viruses. The other organic molecules include glucose, and amino acids, and urea. Gases like oxygen, carbon dioxide, and nitrogen are dissolved in the saliva. The other components, especially whole saliva, and the cellular components like WBCs, epithelial cells from the components of the lining mucosa, and we also find food debris in the saliva. Now, moving on to the functions of the saliva, it is protective in nature. How does it protect? It protects both the teeth, the hard tissues, and the oral mucosa. It protects the teeth by neutralizing acids. How? The bicarbonates in the saliva acts as a buffer. It neutralizes acid produced by the bacteria, thus helps prevent tooth decay. Secondly, It helps in dilution and clearance of saliva, flushes away the sugars and other substances that contribute to caries. Now, antimicrobial action. The lysozymes and the lactoferrin, thiocyanine, salivary peroxidase, and other components, they inhibit the growth and the adhesion of the karyogenic bacteria. So they are bacteriostatic and bactericidal in nature. And components like histatin has an antifungal property. They limit the growth of the oral yeast, inhibit and kill the candidal organisms. Lysozyme also contributes to antifungal property. These components, along with the mucosal tissue, are an innate immune system. Immunoglobulins in IgA and IgM help protect and heal the oral mucosa. Remineralization also happens. Like, for example, minerals like calcium, phosphate, and other fluorides, they help aid in the repair of the early caries. Now, lubrication and the mechanical function, how does it happen? The saliva, mucins, glycoproteins, they form a coating over the teeth and the oral mucosa. So this protects against mechanical, thermal, chemical irritation, and it helps in speech and swallowing. It also moistens the food bolus, which helps in mastication and swallowing. So this salivary glycoprotein forms a pellicle, a protective layer on the tooth surface. Now, healing. Saliva also contains certain growth factors which stimulate epithelial growth to promote healing. So taste, the solvent action and hypotonicity of the saliva enhances tasting capacity by allowing interaction between the nutrients and the taste buds. Saliva as a diagnostic tool. It is a very powerful tool. It is effective, non-invasive, cost-effective, and it helps in detecting dental caries, periodontal diseases, and various other systemic conditions. There are biomarkers like proteins, enzymes, DNA, RNA, and metabolites, which helps us to analyze the disease risk. They also aid in monitoring the disease progression, and they detect early cancers and other systemic conditions. With respect to the oral diagnosis, especially with dental caries, the bacterial counts, enzymatic activity, and the presence of biomarkers like MDA help us in early diagnosis. And in cases of periodontal diseases, there's an elevated level of inflammatory biomarkers, lactoferrin, MMP8, which help us to understand the state of the active disease and also help us to monitor the treatment response. In cases of oral cancers, the molecular markers like RNA and DNA help us to detect the disease. Coming to the systemic disease, there are indicators from systemic conditions which reflect overall body health. So these help to detect and monitor cardiovascular disease, endocrinal disease, viral and neurological conditions, and they help in drug monitoring. Hormones and drugs are usually not a part of saliva, so it helps in monitoring drug abuse. The main advantage of saliva as a diagnostic tool is they are non-invasive, accessibility is there, and cost effective. Now, coming to the methods of collection of saliva, there are many methods. Among them, these are the most commonly used method: the draining method, spitting method, suction, and a swab method. In the draining method, the subject sits upright, tilts his head forward, and allows the saliva pool in the mouth before passively dripping into a collection tube. This is the preferred method for collecting unstimulated whole saliva. In the spitting method, saliva is accumulated in the floor of the mouth and then deliberately spat into a graduated collection tube every 60 seconds. In suction method, where the saliva is collected by using a transparent ejector, and then there is this absorbent method where pre-weighed cotton rolls swab is placed in the mouth. Now, for collection of stimulated saliva, you can follow these masticatory or the chewing method, where the subject is asked to chew pieces of paraffin and other suitable material which will stimulate the salivary production, which is then spat or collected into a graduated tube. The other method is a gustatory stimulation, where sour flavors like lemon and citrus acid are used to stimulate the salivary production. Now, collection of gland-specific saliva. For submandibular and sublingual glands, we have this cannulation method, segregation, suction cup method, and Wolf apparatus. For parotid saliva, we have this Carlson-Crittenden cannula and Lashley's cup. And for minor salivary gland, we have paper strip absorption, pipettes, filtration paper, and individual collection prosthesis. Now, moving on to the conditions associated with salivary gland dysfunction, that is hypofunction or xerostomia. Xerostomia, which is defined as a subjective feeling or a sensation of the oral dryness, which may or may not be associated with the amount of saliva, and there is no change in the chemical composition of the saliva. Whereas in hypofunction or hyposalivation, there is the reduced salivary secretion rate, that is, the flow rate is reduced. Xerostomia is just a symptom, and there are multiple causes, commonly due to multiple medications with the elderly age groups. Based on this, it could be temporary or permanent. Temporary, mainly due to emotional conditions, fever or dehydration, and permanent in cases of silolithiasis or aplasia. As mentioned earlier, unstimulated whole saliva flow rate when it is less than 0.1 to 0.2 ml per minute, and stimulated flow rate when it is less than 0.1 to 0.2 ml per minute. Clinical features of xerostomia: we have dry mouth, that is a symptom which patient usually complains. Then halitosis, because the cleansing function is affected. Dysphagia, difficulty with swallowing. Dysphonia, difficulty in the speech, difficulty in wearing dentures, oral thrush, and burning tongue. Now, how to diagnose the salivary gland dysfunction? There are different methods. So, the clinical method, we have the Tellecom scale. It's a simple tool to detect the sign of low salivary flow rates. Scores from 1 to 10 are given. In the 10 is the severe score. So, it is based on the number of criteria: the mirror sticking to the buccal mucosa, the frothy saliva, the absence of saliva, pooling of the saliva in the floor of the mouth, tongue lobulation and fissuring, debris on the palate or the teeth, and the shining palate. Now, silometry, as explained in detail in the methods of collection of the saliva, you have to measure the amount of saliva collected. We have the same draining method and chewing method. Draining method for the unstimulated and chewing method for the stimulated. Filter paper, we can use filter paper with a gentle pressure for 10 seconds. Micro moisture meter, usually done for the unstimulated saliva. The imaging in specific patients, we have this ultrasonography, salivary gland hypofunction, especially the lymphoepithelial lesions. Xylography, that is by injecting a contrast dye, which is less common because of the advent of CT and MRI. We have this scintigraphy, where we are injecting technetium sodium, and it's an imaging technique. Coming to serology, it is helpful in cases of autoimmune disorders. We have this anti-nuclear autoantibodies and the rheumatoid factor in cases of Sjogren's syndrome and lupus erythematosus. Biopsies, especially in cases of lower labial mucosa, to confirm Sjogren's syndrome and IgG. Now, moving on to the causes of xerostomia, there could be multiple causes of xerostomia: developmental, iatrogenic origin, like medications, radiation therapy, or chemotherapy. And it could be because of some systemic diseases like diabetes mellitus, HIV, hepatitis, psychogenic disorders, nutritional deficiency, or local factors like in cases of mastication, smoking, mouth breathing, then autoimmune disorders like the Sjogren's syndrome. Medications and the salivary hypofunction, as mentioned earlier, could be due to medications like anticholinergics like atropine and antidepressants, antitryptyline, decongestants, pseudoephedrine, or antihypertensives like calcium channel blockers, and then reserpine, furosemide. Medications like anticholinergic affect the fluid imbalance. Studies have shown that 50% of non-institutionalized adult population use at least one prescribed medicine, and especially women more than 65 years have the highest numbers. Other studies suggest that salivary gland with older persons are more susceptible to medications with anticholinergic effects. Moving on to the radiation and its effect on xerostomia. A common therapy for the head and neck cancers is external beam radiation, which causes severe and permanent salivary hypofunction. In the dose when it is more than 60 degrees, there is an irreversible damage happening to the salivary glands. And now, how can you avoid this and prevent radiation-induced xerostomia? You can use emifostin, which is a radioprotective agent, which is given intravenously 15 to 30 minutes prior to the radiation. Then other technique is by doing IMRT, that is intensity modulated radiotherapy, and proton therapy, where the energy is deposited to the targeted specific cells. And with internal radiation, radioactive iodine is used. It also causes damage, but in comparison to external, it is less. Xerostomia and autoimmune disease. Sjogren's syndrome is the most routinely found autoimmune disease, and it is an autoimmune disorder described as a triad of keratoconjunctivitis, xerostomia, and rheumatoid arthritis. Here they are of two types, primary and secondary. In primary, mainly the salivary glands and the lacrimal glands are involved, whereas in secondary, along with the glandular involvement, there is this extraglandular involvement in with systemic conditions. Treatment could be ocular lubricants, salivary substitutes, maintenance of oral hygiene, frequent fluoride applications, and Silovox. Now, here is a list of guidelines for the treatment of patients with decreased salivary function according to the DCNA. First, we need to establish the cause of the decreased salivary flow rate, whether it is because of Sjogren's syndrome or because of multiple medications taken daily, or whether there is any significant anticholinergic effect. Then, depending on the internal or the external radiation treatment, or does the patient have multiple systemic illnesses? Now, what are the preventive measures you're supposed to take? We need to remind the patient about the high significance of dental caries, and ask the patient to use less sugared products. Then you can prescribe fluoride supplements for the prevention of caries. Then recall the patient every 3 to 4 months for the checkup. Then you can ask the physician for an alternative medications to see that there is improved salivary flow. Then discuss with the patient's oncologist the possibility of using radiological techniques which can spare the salivary glands from radiation. Now we need to administer the symptomatic treatment, like encouraging the patient to sip waters throughout the day and recommend the salivary substitutes or the coating agents. Then we can recommend humidifying the environment. Now, how to promote the salivary stimulation? We can ask the patient to use sugarless candies, mints, or gums to stimulate the flow. Prescribe pilocarpine or gabapentin for 2 months, if not medically contraindicated. Then you can discontinue if there is no improvement in the signs and symptoms after 2 weeks. Now we need to plan a proper restorative treatment. Early diagnosis of caries and intervention is essential. You can select a direct resin restorative material where it has got a fluoride releasing property. Make every effort to do no harm. That is, like in some cases, it is acceptable to do less treatment rather than being more aggressive. And the treatment should be such that the patient can maintain it. So before providing extensive restorative treatment, determine that the patient can maintain it. Now, the salivary substitutes and the stimulants. Artificial saliva contains a mixture of buffering agents, cellulose derivative, and the flavoring agents. It does not contain digestive and antibacterial enzymes. Now, what are these different types of salivary substitutes? You have immunologically active salivary substitute, carboxymethyl cellulose combination, then the oral moisturizing gel, Biotin Oral Balance, Bio Extra Gel, and others. Now, coming to the salivary stimulation, could be local stimulation or systemic stimulation. In local stimulation, chewing gum, mints, inert substances like paraffin, electrical stimulation like salipen and salival. Salipen is an handheld electrode. It is placed in the sublingual area and it helps to stimulate the saliva. And the salival is an implant-supported crown and is fixed intraorally. It also helps in continuous stimulation of saliva. Now, systemic stimulants like Salivox like pilocarpine hydrochloride, bethanechol, and cabemelin can be used. Acupuncture is one of the non-pharmacological methods of stimulation, which increases the parasympathetic activity, hence increase the salivation. Coming to the prosthodontic considerations with respect to hyposalivation and hyposalivation, how it is going to affect our treatment modality. Now, potential oral manifestations secondary to salivary gland dysfunctions are mainly eating and swallowing difficulties, halitosis, infection, salivary gland enlargement, silolithiasis. Then you have this poor denture adhesion, stability, and increased likelihood of traumatic ulceration and frictional keratosis due to the loss of lubrication. The role of saliva in the retention of dentures, as we have all studied and understood it in our undergraduate classes, like adhesion, cohesion, interfacial surface tension, capillarity, and viscosity, how these factors help in the retention of the complete dentures. Now, moving on to adhesion, it is the physical attraction of unlike molecules. The thin and mucus type of saliva is an ideal condition for good retention. Thin and watery is not effective. Thick and ropey, very adhesive, but tends to build up, especially in the maxilla and pushes the denture away. Cohesion, it's a physical attraction of like molecules within the salivary molecules, which aids in retention. Normal saliva is not very cohesive. Hence, the retention mainly depend on the adhesion and the surface tension. Interfacial surface tension, it is, the capillarity or the capillary action, it is that quality or state because of the surface tension which causes elevation or depression of the surface of the liquid that is in contact with the solid. Where there is a close adaptation between the denture and the mucosa, a thin film of saliva tends to flow and increases its surface contact, thereby increasing the retention. Now, how does this interfacial force help in the retention? It is defined as the tension or a resistance to separation possessed by the film of liquid between the two well-adapted surface. It plays a major role in the retention of the denture. Now, moving on to the role of saliva in the mucosal secretions during impression making. Fovea palatini are the indentations. They are found on the mucosa near the vibrating line. What are these? They are nothing but coalescence of several minor mucous salivary glands, ducts, and it is a very critical anatomical landmark in the midline near the vibrating line. The secretions from these ducts makes the maxillary impression uneven and irregular. Hence, it becomes mandatory that the palatal area is wiped with a dry gauze before making any impression. Now, role of palatine mucosal secretions on the extent of maxillary denture. Fovea palatini position influences the position of the posterior border of the denture. The denture may extend 1 to 2 millimeters across the fovea palatini. Thus, a thin film of saliva spreads over the denture base area and aids in retention. If saliva is thin and mucous, which is very ideal, but in case if saliva is thick and ropey, it gets accumulated and creates a hydrostatic pressure which will displace the denture. In such situations, the fovea palatini should be left uncovered. Now, siloria. What is siloria? Siloria, it is a chief cause of siloria in denture wearers is due to emotional stress, reflex and stimulation of dentures, which in turn could be due to incorrect central jaw relation, excessive VD, overextended borders. All these conditions increase the salivary secretion. There is a reflex stimulation of the dentures. Denture act as a foreign body. So when we give, if it's a first time denture wearer, there is always a chance of increased salivation. So we should tell the patient before that for few weeks you will have increased salivation, and once he gets adjusted, it comes to normal. Then the excessive thickness of the dentures, and then patient's anxiety. Now, how do you manage these? Correct the dentures, reassure the patient, and then the psychotherapy of the patient. Now, denture stomatitis. It is the adherence and the growth of microorganisms on the acquired dental pellicle, results in granular and inflammatory response by the underlying mucosa causing denture stomatitis. Commonly occurs in the maxillary palatal surface. Now, what are the prosthodontic implications of xerostomia? Mainly, retention is affected, frictional irritation to the denture supporting tissues. There is difficulty in mastication and deglutition, and patient may discontinue the use of the denture. So now how do you manage? Ask the patient to use the denture for minimum short periods, then give a nutritional supplements, soft and moist diet, good denture hygiene, frequent liquid intake, small sips of water and chewing sugarless gums, fluoride application and pilocarpine therapy. You have this rechargeable muconazole loaded denture based material. They are useful in the management of refractory denture stomatitis, which is a fungal infection. Salivary substitutes as a salivary reservoir in the dentures or the salivary sprays can also be used. In the salivary reservoirs, which is a small chamber which is built into the prosthesis for the slow release of artificial saliva, which provides continuous lubrications. There are mainly two types: non-functional salivary reservoirs and functional salivary reservoirs. Under non-functional salivary reservoirs, we have this detachable hollow cheek plumper, palatal reservoir with acrylic lid, mandibular split denture using Lego block, mandibular split denture using metal rods, and then we have a mandibular split denture which is using interlocking grooves. Under the functional salivary reservoirs, we have this maxillary reservoir with shallow palate, maxillary reservoir with flexible lid snap onto it, and a maxillary palatal reservoir. And we have this false palatal reservoir. Now, coming to the role of saliva in overdentures, during chewing and mastication, proprioceptive signals contribute to the Masticatory salivary reflex. It's a neurological feedback that stimulates saliva secretion. A network of proprioceptors and mechanoreceptors are activated during chewing, which are found in the periodontal ligament, masticatory apparatus, TMJ, and the oral mucosa. The amount of saliva produced is directly proportional to the chewing force and time. Hence, in completely edentulous patients, there is impairment of this mechanism, regulated salivary secretion. Now, caries and periodontal diseases in the abutment. Select the teeth with minimal or no caries as an abutment. The lack of saliva leads to caries and failure of the prosthesis. Thick viscous saliva leads to more plaque and calculus accumulation around the abutment. Saliva plays a profound role in removable partial denture. The presence of a thin salivary film is essential. And enhances the occurrence and whereas xerostomia enhances the occurrence and the severity of the caries and contribute to the irritation of the oral mucosa. The need for protective and preventive restorations is there, and we need to avoid the intracoronal restorations, avoid gingivally approaching clasps. Then denture components should not cover the gingival margins. Metal-based material preferred to it due to its wettability. Then a combination approach of fixed and removable to rehabilitate partially dentulous patients is advantageous. Now, role of saliva in the fixed partial denture. Coming to saliva and caries, as already explained, our saliva has a protective mechanism. It forms a coating and helps protects the tooth from caries. In patients with xerostomia, high chances of caries to develop. Hence, at each post-operative appointment, thorough dry and inspect for the carious lesions. Now, moving on to isolation, especially in cases of sialorrhea where there is increased salivation, saliva obscures the field of operation. Hence, there are various methods of isolation like fluid absorbents, saliva ejectors, rubber dam, and pharmacological methods which aid in the accessibility and visibility in the work area. All these methods of isolation help in the accessibility and the visibility of the work area. Now, oral galvanism, saliva acts as a electrolyte. There's a sudden galvanic shock between two dissimilar metals. Due to the acidic pH in cases of hyposalivation, there could be release of several other elements from the ceramic grounds like silicon and aluminum will be released, and the nickel and chromium from the PFM ground, which are known for human carcinogens. Now, disintegration and the solubility of the luting cements, proper isolation and maintaining dry field is very important for the adhesiveness and the strength of the luting agents, especially the GIC. Now, role of saliva and dental implants. Salivary proteins form a coating which retain a microbial biofilm, which leads to peri-implantitis. Hence, it needs maintenance and regular follow-ups. In patients with severe xerostomia, fixed implant supported bridges have been a preferred treatment modality. So it's very, very important that after implant placement, maintenance is very much required. Now, in recent advances, Netherlands Cancer Institute was working on radiation toxicity among prostate patients, during which they found that these pair of salivary glands, which can be considered as a fourth major salivary gland and name them as tubarial glands, they are found on the lateral wall of the nasopharynx. They were identified during PET-CT using PSA, that is prostate-specific membrane antigen, which is used to detect the spread of the prostate cancer. So the future directions in salivary diagnostics is that saliva is a cornerstone for the future advancement in non-invasive diagnostics. The diagnostic research is heading towards a revolutionary new path. Glucose monitoring in diabetics, stress-related hormonal swings, gives a quick feedback and allows a real-time evaluation of biomarkers. More studies for early identification of zoonotic infections on antibiotic resistance should be conducted. Mass screening and public health crisis, highlighting the need for cooperation between the technology developers, physicians, and the legislators is required. To conclude, this presentation provided a fundamental overview of saliva production. In addition, highlighted the various clinical manifestations secondary to the salivary gland dysfunction. Theoretically, all restorative treatment options are available, but in reality, oral and systemic health of the patient often dictates modification of the treatment. As oral health care providers, we should institute aggressive preventive measures for dental caries and to prevent the periodontal diseases. Then we have to recommend palliative care for patients with significant reduction in the salivary gland functions. Then we have explored salivary biomarkers for screening and systemic diseases. We have discussed the management strategies for patients with salivary gland dysfunction. Then we have outlined the prosthodontic implications of saliva and the salivary gland dysfunction. Most commonly asked questions in the university examinations, like for the 10 marker, they are like the role of saliva in prosthodontics, discuss saliva functions, clinical significance and physiology of saliva, discuss the composition of saliva and its role in prosthodontics, saliva and its physiology. These are the references you can go through. Thank you.